Thank you so much.
Yeah. Thank you. Hello, everyone. I'm very curious. Just some questions to you, who's in the room. If you're a student, an active student, would you raise your hand? Okay. If you're a graduate student, which includes medical school, nursing school, public health school, would you raise your hand? Okay. Faculty? Oh, okay. Awesome. If you've lived and worked overseas more than a year, would you raise your hand? If you come from another country, would you raise your hand? All right, so this is a group of experts, and so I have to really raise my game here because a lot of you know much about what about what I'm going to be talking about. I just want to point out in this front piece that you'll see Global Health Fellows Program. That's a project that I run. It's funded by the United States Agency for International Development, largest international development donor in the world. The bottom, the Public Health Institute, that's the NGO, that's the company I work for, that's based in San Francisco. I live and work in Washington, D.C. I have secret security clearance, which means that Ivanka Trump is going to have a higher security clearance than me, and it really bugs me, I just want to say. All right. There's like this really beautiful brochure that this group put together, and I have like all this stuff about me. So I'm the only things I want to say about me is that I don't have a health academic degree, but I used my degree in counseling and organizational consulting to move into global health from international education through family planning counseling, client-provider interaction, training, and performance improvement. So those were and behavior change communication were the technical programs that I was a part of. I've worked in many countries, but I've only lived outside of the U.S. in 3. Strangely enough, the Netherlands, Tanzania, and Japan. And the 3 most transformative experience in my life have been, number 1, working in Johnson's wax factory in the Netherlands with 5,000 Moroccan guest workers. 2, working in Kigoma refugee camp after the Rwanda genocide. And 3, working in a UN-funded project in Yemen, developing a new cadre of health workers, which were midwives, and trying to keep them alive. So I want to talk about all kinds of different things. Really, the last 15 years, my projects have been you. It's been about helping to build that next generation of global health professionals, as well as meeting the needs of the human capacity needs of USAID. So fellowships are 2 to 4 years. The website is up there, www.ghfp.net. Their early career to, I'll poach anybody. Early career to faculty, come on board. They're 2 to 4 years. They're in Washington and also in the missions overseas. And they're well paid. We also have a really robust internship program as well. And all the information and how you apply and all that is on our website. I want to talk sort of big picture in terms of some of the big trends that matter. I realized last night they had 40 minutes worth of conversation, so I just dumped out this morning a lot of slides. So we'll see how this goes. But I want to just start really big and have you look at now this is stuff you know about already, but I want you to look at it from a career point of view and kind of how you collect big data to help you figure out where the market is going to be in terms of positions, where the need is being funded, if not identified. And so a couple of the big things are, one is the youth bulge. 1.8 billion people on the planet are between the ages of 15 and 24. And 89% of those are in LMIC, lower and middle income countries or developing countries. people go back and forth in those descriptions, by the way. Example is Zambia, where 75% of the population is under 25. So that has a lot of implications for health programming and health needs. So just suggesting you pay attention to that. Migration, refugee, I mean, that is, the UN has identified that as the number 1 issue facing the world today, and you know that from your own just reading the news. Another aspect is national security. This has been used very smartly by the State Department and USAID and CDC in terms of getting secured funding, by really helping people understand that health is a national security issue. That if you look at it from that lens, and I think one sort of example of that is Ebola in the national news. When Ebola started threatening the American population, Congress really could not give enough money. They were looking for people to give funding to. So that is something that is, and it's true. It's not just political, it's true that borders, in terms of national borders, are irrelevant when it comes to infectious disease and threats. And then there's the idea of multi-sector alliances, multi-sector systems. Global health development is really done in groups now. It's done in teams. It's done in multi-government organizations like Global Fund, MCC. It's really important to understand that health happens in a larger context, and global health development professionals are being pushed to understand how poverty, how inequity, how politics, how climate change, how technology all sort of factors in. And I'll mention that again when I talk about career trends. So what's been happening for us is I've been running fellowship programs in global health now for 15 years, and one of the things we do is a ton of outreach. Annually, we go to between 50 and 80 schools talking about careers in global health, and we also talk about the United States Agency for International Development and all kinds of things. And over the years, what we've been noticing is that the number of schools that have global health programs is really increasing dramatically. And the data here is, it started, now these are not tracks or minors or certification programs, these are full-on comprehensive global health programs. There were about 6 of those in 2001, and as of last year, there were over 250. And so why is that happening? Well, we think it's happening because you're asking for those careers. You're asking for those programs. And if you think about it, and it was hinted at before, you know, your thinking is being influenced by globalization, by technology, which allows you to be more connected to the world. I think personally it's also where we are as a species, that there's something in us that is this knowledge and this wisdom about the idea that we are all one, and that the suffering of others matters to us. And so that is really driving this huge explosion in academia of global health work. Now, you know, academia is not stupid. They know that, you know, there's a market here. So that's why all these programs are coming. But one of the problems that we were seeing, one of the things that we're noticing is that in order to provide you with global health experience, one of the things that's happening is that, and this is true particularly for med schools because the curricula is so tight, that they're setting up domestic experiences in low resource environments and in immigrant communities and things like that are completely legitimate global health experience. Let me make that really clear. But you're going to find out how complicated this is career-wise in just a moment. So there's this kind of new conversation going on between local public health, the local public health world or the domestic public health world, and global health. And right now the barriers between moving in and out of those careers are not very permeable. It's something that we would really like, we would really like to make a difference in that arena, but you're going to hear about why that's a problem. Okay, so the reason I'm calling this the perfect storm is that while there's this big desire to do global health work, the fact is that jobs for Americans, particularly overseas, are decreasing. There's fewer positions for Americans overseas, and in a way that's really good news. That means that international development is really doing its job, right? And that there are more national public health professionals who are able and should be taking those positions. But where Americans used to go in and do, they used to be working in, they used to be project directors or technical directors or evaluation directors. More often than not, those positions are being taken, and rightly so, by national professionals. The other effort that has influenced that is Obama created a global health initiative, and one of the key aspects of that was country ownership, and that's been taken on by the Global Fund, by Gates Foundation. So there's a lot of requirements that field work is staffed and led by nationals. So that's great news, except if you're trying to break into the field as an American in global health. So it creates some special challenges for you. So we were curious about this. So last year, we did a study, and we call it the employer study. It just got published in the Annals of Global Health. And what we were looking at are we were looking at the hiring practices of major global health employment organizations. So we queried almost 50 experienced senior global health program directors about their hiring practices. And we asked them sort of what was that interaction between academia and the work that you hire people to do. And I want to say that the University of Pennsylvania is totally exempt from all negative comments related to this study. I'm just putting that out right now because I'm here, and I just had a great meal at the White Dog last night, and I've met some really lovely people, and I actually think that the leadership here is doing God's work when it comes to global health. However, these employers said this: 85% of academia can and should do a better job of preparing students for what the work actually is, knowing that that work is evolving very quickly. What they wanted to emphasize, they said that in terms of clinical skills, and I'll talk a little bit about what that means, in terms of clinical skills, academia is really great. The students that they hire, the graduates that they hire, are really up to steam. They really have a depth in terms of that type of technical work. But what they're missing, and then the companies have to do in-service to get them back up to steam on this, are things like project management, strategy, and project design. Like, how do you write a proposal? Those things are missing in your prep. Maybe not here, but maybe. And then they're also feeling like what academia could do better is as this high-level skill related to collaboration and teamwork, communications with the counterparts in the communities, which is such an embedded part of development. And so my sense is that that gets embedded in all of curricula. The best academic programs I know, it's sort of not one class, it's in every class, and it's taught by every faculty person. But sort of be aware that these are some of the deficits they're talking about. Then we asked them, well, what do so do you hire people that have domestic-only experience? So what's your history about that? And they said, oh, sure, we hire people that have domestic-only experience. And then we did the second drill down, and what we discovered is that if they have 200 staff, maybe 4 or 5 they've brought on with domestic-only experience. And the reason that they hired those people is because they had some sort of technical depth that was of particular interest to the employer. But in general, they don't. And one of the reasons they don't is because they don't have to. they have people that have global health experience with the technical backgrounds and all of that. So that is something that I thought was very interesting. So we said, well, why don't you hire domestic-only professionals who want to work with you? And these are some of the things they said, and I'm sorry it's not super easy to read, but the most common reason that they don't hire domestic-only health professionals is they don't think that they understand the context and the realities of global health. So that's the most common reason. The other common reason, the only one that I actually agree with, is the last one. I don't think this is working. It's the knowledge of key players, systems, and processes. Okay, so those two reasons are really valid, and I think academia needs to pay attention to those reasons why those biases. But this middle area really bugs me, and it's this the third most common reason they don't hire domestic is because they think they lack characteristics like flexibility, adaptability, and creativity. They also lack cultural sensitivity, and also they lack cross-cultural communication skills. Doesn't that like bug you? I mean, that is so unfair. And so really when I talk about this in academic environments, I say to academia, guys, we have to change the minds of global health, these big implementing partners, these big companies that get all the money and implement global health programming. We have to change their minds, and that is a communication campaign. So, all right, so let me talk a little bit more about some of the big recommendations then that we now say. Do we have any undergraduates in the room? How smart are you guys to be like gathering this kind of data before you make your ultimate decision about graduate school? I'm like, hats off to you, really. So here's the thing. When you're looking at graduate programs, you might want to think about kind of how careers fit into big buckets, and they're all sort of like, there's tons of flexibility about how you move in and out of these careers, but how I sort them for myself is there's direct service, right? There's like you're a doctor or a nurse or you're a counselor and you're working directly with patients, and humanitarian relief as a category has a lot of that direct service quality to it. And then there's research. And so that's you're creating new knowledge, you're curious, all of that. And what I find is that when you want a research career, ask your faculty where they're getting their money for their work, right? And if all their grants are NIH or sometimes CDC, then you're going to get a depth of research that's going to really be useful for you. However, if you want to work in development, which is taking the research results, designing programming, implementing that programming, monitoring, evaluating it, that world, it takes field experience. You have to have had field experience to get into the work. And it's a vicious cycle because if you want to do development, they want you to have worked in the field. But if you haven't worked in the field, it's hard to get into development. And so it's a nasty thing. And the best programming, and I heard about this at the University of Pennsylvania, there's so much programming here that allows you to get into the field for the work. And I think that's a big kudos. The other thing to be looking at is, does the curricula really address the needed competencies? And I'm going to go into the 4 competencies that actually really matter and paying attention to that. But you've already heard that team building, collaboration, that's massively important. And so paying attention to how your program allows you to come out the other side with not only technical skill in that, but an ability to talk about that to an employer. And sometimes you have to look outside the core curricula for that, like weekend workshops from the psych department or the business school or some other, or Google and LinkedIn, and these companies are actually creating their own universities in order to teach some of these things. And then really seeking overseas practical experience. So I want to go through the 4 competencies that I think is just an easy way of paying attention to what actually matters. And I with a group of 1 million people, published an article a couple years ago on intraprofessional competencies in global health. And we started with like 750 and worked our way to 100. But in the end, I think there's only 4, because that's all I can remember at this point in my life. So this one, let me see where I am. This one is really academia's sweet spot. It's health, it's the technical, clinical expertise arena. And this list it's called the Backstop 50 list. This is the congressional earmarked list where money is actually earmarked. And I'm talking, the Global Health Bureau's funding at USAID is almost $6 billion a year. So it's big money that then funnels into these particular areas. And you can, I won't talk through them, but I just want to note that the ones that I've starred, family planning, reproductive health, environmental health, gender equity, and special populations, are the ones that are right now most at risk. And we in USAID, because they're my client, I support them, and I also get a lot of money from. Does that mean is my time over? Okay, no. Is it over or should should I 5 minutes? That was really not so at all, Brian. It's like now you just shamed me in front of everybody. So I really appreciate that. But now it's so funny. It's okay because these slides are going to be available to everybody, because then you can go through them, and you have my email address as well, so we can follow up further conversations, and I'm also around through lunch. Okay, so that's the technical stuff. The second is knowledge management. I want to give a shout out to our engineering professor, because he's actually super cutting edge on what is important. Knowledge management is the number 2 it's the number 2 competency area that you want to pay attention to. I happen to know for a fact that one of your faculty members currently, at this moment, has 9,000 unread emails, right? So this competency is about your ability to manage the information that's coming to you, to be able to sort. The total sum of all human knowledge used to double every 400 years. Now it's doubling every 3 to 4 months. So your ability to go through research, figure out what's worthy and what isn't, sort it, keep it in spaces where you can access when you need it, that's a whole competency area. Your ability to understand technology, I can't really underemphasize the importance of understanding how technology and information technology, how it's transforming everything, academia, how health is created, how it's reinforced, how people understand and know about health, all of it is being transformed. So keeping on top of that is really important, plus these other 2 things. All right, global health business processes. Okay, understand strategy. Understand how a project is designed, understanding how to write a proposal, understanding how to monitor and implement a project. Those are project management skills. You can get those on the side. You can actually get certified in project management, and it will move your resume up to the top of the list, frankly. Understanding who the donors are and how money flows is absolutely crucial. But the most important one is interpersonal effectiveness. And the reason I say it's the most important one is that in the course of my years supervising fellows, the only reason I have ever had to fire fellows, and I do, no matter how junior or senior they are, is because they don't know how to work in a group or they don't know how to work in a team. They're all brilliant. They are all smart. They all have technical depth that is beyond my comprehension. But if you can't get along with people, you can't do global health. If you go into the field and are rude and abusive, you shouldn't be doing global health. Okay, so what's the future look like? One is there are some shifting technical health areas. Infectious disease is going to never go away. But there are new things, chronic disease, diabetes, cancer, those things are mattering because more people are dying of those, particularly in emerging economies. Pandemics, we're watching China right now for the infection that's there. The new H something N something infection is kicking back in. It's a new strain. You guys know more about that than I do. People are shaking in their boots at WHO about that. Key populations, we'll see how that shifts. The youth is going to always be an issue. Monitoring evaluation, but not just any monitoring evaluation, turbocharged technology. I'm now hiring more and more fellows about who understand and can talk about big data. I don't even know what that means. Big data analytics, you know, PEPFAR's done this great job of huge, massive data streams, and now they're trying to figure out how to make sense of it all. Then there's data visualization. That's another set of fellowships. Business skills, which I've talked about before. And understanding how these multiple specialties work together. If you have a narrative that says you know how climate change connects, you know how energy connects to health, you know how equity, poverty connects to health, that's a narrative which is becoming more and more important in global health, and more people are hiring. And then always scaling up. How do you take that great project and embed it in a health system that will last longer than you? Okay, here's the best career advice I ever have taken and have given. There's 3 questions that you want to ask yourself in 30 seconds. Okay, number 1, what do you love to do? Nobody loves everything about their job, right? But if you are awake to your world, if you are present as you go through your week, you will become aware that there are some things that you love, and students too. It's just like, you know, there's moments when you're just in your sweet spot, right? You're just like, oh, this is like, this is right. And it feels like everything's aligned, everything, like you're doing something that you were meant to do. That's where you want to pay attention to that. The second question is, what am I good at? Not only what you think you're good at, but what kind of feedback do you get from others? What compliments do you get from others? And they're not always the same. What you love and what you're good at are not always the same, but sometimes there's an intersection there that matters, and you pay attention to that. It gives you data that helps guide your career choices. The other thing in particular in global health is, where do I need to be geographically? Sometimes, especially in early career, you need to be overseas. You need to be living and working. You need to have, just like Dr. Schulman and Glenn was saying, you need to have that grounded experience. It's easier to get that in an overseas living experience and things like Peace Corps or early career, because nobody makes any money doing that. Pretty soon, you're going to want to make more money, and so you're going to want you're going to want to evolve in your career. So have that as soon as you can. You go back and forth forever. As Dr. Schulman was saying, sometimes you just like, the travel is just too much. You know, it takes a toll over time. The other thing is, you know, where do you want to, if you want to partner up, are you partnering with somebody who loves global health like you or not? Are you going to do dual career? Sometimes you have aging parents and you have to come back to the US. So there's a lot of answers to these questions that change over time. So these are the 3 questions, and now it's all what it means to you. Because all this information you have to weight it, you have to make it unique to what it means for you in your career. And with that, I'll give the podium back.
So apparently the timer on an iPhone overrides the silence feature on the side. It's good to know for future moderating gigs if I'm ever invited back after this. All right, so next we have Sean Bloffus, who came up from Baltimore to be with us. So Sean earned his bachelor's at University of Washington and his MPH at the Johns Hopkins Bloomberg School of Public Health. Yeah, that's right, where he designed a customized concentration in social and behavioral sciences and epidemiology. Prior to this, he served with the Peace Corps in Ghana, and that's where he first fell in love with malaria. It was probably a love-hate relationship over the years. Sean currently works for the Johns Hopkins Center for Communication Programs on a malaria prevention and control project called VectorWorks, and I'll let him talk more about that.
All right. First, if you guys wouldn't mind doing me a small favor, could Sector 2, could you guys scoot up a little bit into the, you don't have to go first row, but if you guys could all come up to the second row and beyond, that would be great. Thank you. All of you. What have I done? Oh, great. So Global Health and Me, Goat in the Darkness. This is, the title is an homage to the goat that kept me up in my Peace Corps village for 2 years at 3 a.m. And while I was preparing this presentation, I had the pleasure of going through a lot of my old photos and kind of laughing about all the hard times, sort of the times where you're uncomfortable. And I thought that's sort of a really good microcosm of my entire global health experience. If you can look back on things in the future and laugh about them that were uncomfortable at the time, then global health might be for you. So I prepared this presentation sort of with the idea, and I think it'll be a nice compliment to Sharon. Sharon had a very macro view of where global health is going currently and in the future, and mine is sort of my personal story, how I got into global health, and I think they're going to interact very nicely. So as Ryan mentioned, I started off as a Peace Corps volunteer in Ghana. In college, I had a few opportunities to go to Haiti and to Tanzania and sort of had some of those classic 3-week volunteer experiences. And probably from those, I learned 2 things. One, I felt that access to healthcare and health systems is an inalienable right that should be available to everyone. And 2, I really enjoyed being out in the field. And so I wanted to explore more. And for a lot of people, I think later I'm going to tell you that global health, there are many entry points into the field. People come at all ages, from all backgrounds into the field. But I kind of do have more of a sort of classic route into global health, I think, starting off with the Peace Corps. So I was in Ghana in the Western region from 2011 to 13, where I was a health volunteer. Really neat opportunity to sort of go into a community, do a needs assessment, sort of figure out what was going on in the community and try and implement some programs. And like the majority of Peace Corps volunteers, I struggled for the first year. There's a lot of contextual factors or sort of social things going on, behavioral things that you just don't understand, and so you're very likely to fail with these projects. You probably take too much ownership over them, and rather than letting the community lead, and I think people over time figure that out, but it's something that's essential if you're going to have a global health career, to let the community leaders, the people in country lead, and you sort of have to relinquish some of that control. The biggest program that I did there, I worked with community leaders in sort of my biggest town near me, the market town, I guess, Sefia Sainso, to develop a radio program. And the radio program was based on malaria prevention messages, and every night at 9 o'clock, it sort of mirrored something that happened in the US in the 1980s. So in the 1980s, there was a night watch campaign, where are your children? It's 9 o'clock. And so we kind of did the same thing, asking parents if they knew if their children were safely tucked under a mosquito net. And for me, like I said before, Peace Corps was sort of where I developed this idea of what is context, why, if we give 1 billion nets over a decade to sub-Saharan Africa across the entire continent where malaria is endemic, why hasn't malaria gone to 0? Like, what are the contextual factors? Why aren't people using them? Why are they getting everywhere? What's the net culture? What is net culture? Some of these factors. So I started to develop a relationship and to explore these ideas. And I think from here I figured out, I don't know anything. I can see problems, but I don't know how to talk about them. And I certainly don't know how to deduce what really needs to be done to solve problems. So then I decided to pursue an MPH at Hopkins. And as Ryan mentioned, I did a customized track. Epidemiology, I think my faculty advisor said it was like epidemiology is a way to approach a problem. And I agree with that. I think it is a really nice background. If you're going to do public health, you need to be able to sort of look at a problem from like the issues. And then the social and behavioral sciences, some of these things that are hard to account for. I wanted to figure out what's going on. You know, why, if someone has a net, won't they sleep under, for instance? And so my capstone project, which is a thesis, I guess, I wanted to do use a mobile app and school network. So using the sort of educational framework to do real-time monitoring of ITN use in a community, and did a research proposal, yet to be funded, but I'm still holding out hope for the future. And I mean, one of the amazing things there was the access to really cool faculty. This picture is actually former Congressman Henry Waxman, who I don't know how many of you have heard of former Congressman Waxman. So he was a visiting health policy faculty or fellow for the year, and it was really neat. He did a series on sort of health policy in the United States and a lot of stuff around the Affordable Care Act, which, again, I come from sort of that international health, global health perspective, and to have this kind of diversity of experience was really important. And then something that I think is really important is, you know, malaria for me, but you need to have a diversity of experiences. You need to sort of try out different things because, you know, I think one thing that global health gets nicked for a lot is being in silos. HIV/AIDS works in HIV/AIDS, malaria is in malaria, reproductive health is reproductive health. So you need to have an opportunity to explore different things because people approach problems different ways, and I think there's opportunity for innovation in particular if you're doing stuff like that. And so I guess I'll talk about this in the next slide, but I worked with East Baltimore schools to expand a health and life skills curriculum from 2 schools to 8 schools with the Living Classrooms Foundation. And this was a great opportunity for me to develop sort of this program management experience. So I was managing a team of volunteers, running around to schools, trying to, you know, make partnerships with schools and explain to them why this is a good idea and how it would work. And, you know, in between classes, going to different schools in East Baltimore was really fun. But also an interesting opportunity to look at sort of the education sector, the local American NGO sort of system and how they do things, and maybe take some of those tools back into my job and what I want to do with international health. And currently I work at the VectorWorks Project, which is a 5-year USAID-funded project that focuses a lot on insecticide-treated nets and sort of the implementation, the policy surrounding them, but also operational research and making sure that we're sort of pushing the field forward and optimizing our approach to, you know, getting nets to the people that need them when they need them. And so the 3 projects or sort of focal areas that I work with now, one is urban ITN distribution, and obviously some of the rural communities, we're actually pretty decent at getting nets to a lot of those communities. Some of the urban settings, when we have to go house to house and register people, it's a pain in the ass. People are gone during the day. They live in high-rise buildings. There's a lot of sort of non-permanent structures, sort of urban slums that are really challenging to enumerate. And so we deal with a different set of factors, but we have national guidelines that sort of drive an ITN distribution when a coordination committee comes together to plan for a campaign. Durability monitoring, I think we're good at access, so when we're talking about making sure that X% of the population has a net, but with the mass campaigns that we do every 3 years or so, you know, from the second a net leaves its packaging, it's susceptible to being damaged, and also the insecticide is wearing off, and after 3 years it may or not be efficacious. And so we have 5 countries that are doing durability monitoring. It's a prospective study, and it looks at the physical characteristics of the net and also the insecticidal integrity using bioassays to figure out how often nets need to be replaced in different settings, and also comparing net brands. There are, I don't know, there are a lot of net brands out there, and we're trying to figure out if, say, one with a different material might do better in a different environment. And then something that actually I'm becoming interested, and I've sort of got hooked on after the last vector control working group meeting for rollback malaria in Geneva, is sort of the relationship between the built environment, particularly housing, and vector-borne disease. Again, in my case, malaria, but with a lot of the 80s born, so chikungunya, Zika, yellow fever, dengue diseases, sort of what does improved housing do for malaria? I think malaria in general has sort of seen a funding stall in the last couple of years, and we're going to have to get creative on how we solve problems. I think we had $2 billion globally, and someone, I think Margaret Chan, and one of the WHO Director General, estimated that we need about $6 billion for all of the programs to be implemented that were needed. So we're going to have to get creative in terms of our approach. And perhaps something like housing and public-private partnerships are a good opportunity to sort of add value through things that are already being done. So what can my experience teach you? In very general terms, like I said, no one path to follow to a global health career. At the Center for Communications, which I should explain to you, let me do that actually. So we work in the social and behavioral change communication realm for the most part. My project, VectorWorks, is kind of the odd duck out. We are more technical focused, but the center was founded in the 80s and it has had a reproductive health focus and family planning for the majority of its time. Only in the last 10 years has it really started to have more of an imprint in infectious disease. So some of the other projects at the center include the Health Communication Capacity Collaborative, and that project works across different global health thematic areas, HIV/AIDS, reproductive health, and it's been involved with Zika and Ebola responses as well. And it works with primarily with government figures implementing social and behavioral change communication programs to raise the capacity for them to do programs that are, effectively disseminating messages to the key beneficiaries and targets. So at the center, we have people with MBAs, we have people who did PhD in communications and really weren't even focused in health throughout that time, but having that communication perspective has been really beneficial to them. There are people with policy experience, so there's really no entry point. I think most people probably didn't think they wanted to be a global health professional when they were a child. I was playing the board game Life a couple weekends ago, and I didn't see that in my career options when I was going through. So people kind of entered at any point. Maybe at 20 you're exposed through a trip somewhere, maybe at 40 you realize that that's your true calling and you want to go into that field. So a lot of entry points, which is a good thing because that means we get varied perspective across the field. Get field experience and get it as soon as you can. And, if you're going to be working in sub-Saharan Africa, living in Indonesia for 2 years probably isn't good enough. You're probably going to need some additional field experience sort of in the area that you're working. And even within that, I would say, make sure you're getting out to those communities that are the hardest to reach, that you're really dealing with. It kind of drives me nuts when I talk to someone who was in Guinea for 3 weeks and I find out they're in Conakry the entire time. You're not able to see where your programs are implemented for the most part, unless it is an urban health program, which most of what we do is in lower income, rural settings, I think. So I'd recommend anyone to get field experience as early as possible and in as varied a setting as possible. Again, seek out diverse opportunities. It's shocking, but not shocking really, that if people have a domestic focus, then there are barriers to entering an international focused sort of career. But particularly when you're in school and you have the opportunity to be involved with 3 very different projects at the same time, I think it's a great step. You have different perspective, or if you're able to do something like work on proposal development or something that's more business focused, that's also going to give you different perspective going forward. And it's also going to add value to any perspective when a prospective employer is sort of evaluating your CV. And the last thing would be to find your voice. And I think you're inevitably going to be doing a lot of writing and a lot of speaking. It comes with the territory. I think it comes with the field. We have to be advocates for what we believe in, and that means sometimes being uncomfortable and standing and sort of talking and telling people who may not be as familiar with your work about what you do and what the larger impact is and the value and why it's important. And it's the same for writing. I'm early career, I guess I'd say, and I do a ton of writing and I do a ton of speaking, and the directors at our center are constantly speaking or advocating on our behalf to politicians or business people. So make sure that you're comfortable with your voice, both orally and written. I think that's very valuable. I think that's all. Thank you.
Okay. And finally, I want to welcome up here Dr. Rachel Churchill. So Rachel and I go way back. We actually started residency together here at Penn, and that was back when interns could work more than 16 consecutive hours, so it was back in the day. Dr. Truchel earned her MD here at Penn. She got an MPH at Brown, and then she completed her internal medicine residency in the primary care track here at Penn. She was actually here during the early days of the Penn Refugee Clinic and served as the clinic's first clinic chief during her senior year of residency. She took a brief break from Penn and worked at Geisinger for a few years as a primary care physician, but we're so lucky that she decided to come back last summer and join the faculty here in the Division of General Medicine at the Penn Center for Primary Care. She's now the medical director of the Penn Refugee Clinic, which has been growing steadily year over year with regard to number of patients and also their medical complexity. So I'll invite Rachel up to the podium.
Thank you all for having me here and allowing me to be part of this panel. I know lunch is coming, so I won't be too long. So today I wanted to discuss my role as the medical director of the Refugee Clinic at the Penn Center for Primary Care and to discuss my pathway to getting in this position. So the Refugee Clinic at Penn started in 2010, and it's a resident-run clinic that has a multidisciplinary team, and it operates once a week where we see patients who have been newly resettled in Philadelphia. We partner with one of the refugee resettlement agencies in Philadelphia, HIAS, and all of the adult refugee patients that they resettle, we provide their health care for the first 3 to 4 months, sometimes longer, that they are in the U.S. And so we, tend to be one of the first kind of faces of the healthcare system that these individuals see, and we provide a wider range of services for them. And in general, we've been kind of steadily growing over the past 6 years, and last year we actually ended up seeing about 130 new refugees who were recently resettled, and so we're seeing a larger and larger number of patients. Things with immigration policy have obviously stalled a bit in the meantime, but we're hoping that we will continue to see robust numbers of new patients in our clinic. The refugees that we tend to see come from a variety of different countries and have been through a variety of different situations and life circumstances. The most dramatic, I think, example of the different refugee experiences come from, so some of our Bhutanese refugees patients have lived their entire lives in refugee camps, and that's obviously a very different experience than our Syrian refugees who are coming from areas where there's intense war and conflict, and they've only maybe been in a refugee camp for 2 or 3 years. So just very different experiences which lead to very different medical complications. So the care that we initially provide to our patients is an initial health examination, and then we screen for a variety of conditions, a lot of infectious diseases. So there's parasitic infections, tuberculosis, malaria, and hepatitis. And we do end up, finding patients with some of these conditions, and we're able to hook them into treatment quickly and get them the care that they need for these conditions. We also get these patients up to date with vaccinations and on track to be able to get their green card, which requires all of these vaccinations having been completed. And then we do a mental health screening, which, depending on where the refugees are coming from, is very important because a lot of these patients have been through very traumatic events and have very specific mental health care needs. And then we also provide gynecologic care for our female patients, which is also very important because a lot of these women have not ever had any gynecologic care, and so this is an opportunity to help. So my team, I've been blessed with a wonderful group of individuals from a variety of different backgrounds. Actually on site, we have a wonderful group of pharmacists who help us with counseling patients on how to take medications, and we have great nurses that that work with our patients. We have caseworkers and social workers from our resettlement agency that come to the clinic to help us with our patients, and then we have a bunch of physicians. And like I said, it's a resident-run clinic, and so we have a group of very enthusiastic residents who really have taken ownership over this population and creating this very robust clinic. We then have developed a wide referral network that we're hoping to expand. We have folks in the OBGYN department and the dermatology department, a lot of different groups that have an interest in global health and seeing our patients. And so we've partnered with them to be able to get these patients access to these specialists, not only just a specialist visit, but also specialists that have some experience dealing with, using interpreters and dealing with patients who are coming from very different, backgrounds. And then in the future, one of the biggest, I would say, needs of our population are very targeted psychiatric and counseling services for our patients. As you can imagine, it's hard enough to find patients in my usual, West Philadelphia practice, psychiatric care and counseling. It's even more difficult to get practitioners to do good psychiatric care for patients who speak a different language and come from such a different clinical background. And so we're working very hard to cultivate relationships with providers who have a background in traumatic care, so for patients with PTSD and other disorders. And we actually now have some Arabic-speaking providers who are helping us to work with some of our Syrian refugee patients, and that's so far been very helpful. So we hope to expand that in the future. We have a few individual programs within our clinic that I'm very proud of. We have a women's clinic. So when I was a resident in the clinic, we basically would do our best to kind of Google, the operation of a female pelvic exam, and we would show them a speculum, and we would do our best. But we have since kind of developed this women's health program where we have medical students come in and spend a good 20 to 30 minutes with our patients and go through a detailed explanation of why this exam is important, what we're doing, what they can expect. And we go through a lot of screening for sexual violence and family planning needs. And we just give them a lot of information and spend a lot more time than we had in the past. One of the things that I think is most important is performing Pap tests on these women, because for most of these women, this is the first time they've ever had a Pap test. And so this is the population where we have the most potential benefit to prevent cervical cancer. So that clinic has been very successful, and now with our partnership with OBGYN, we've really been able to help these patients get, needed family planning services. We've been able to get them IUDs and other services that they need. We have a wonderful pharmacist who runs a latent tuberculosis clinic. The highest risk of reactivation of latent TB is within the first 1 to 2 years of resettlement. And so one of the first things that we do is we screen our patients for latent tuberculosis. We make sure that they don't have active disease, and then we educate them and help them to be adherent with their antibiotics so that we can get them through that 4 months of antibiotics or whatever we deem needed. And then we give them documentation so that they have that then going forward. So that's been very successful for many of our patients. We also have ServiceLink, which is a volunteer group of students that has been helping us with transitioning our patients from our clinic once they're kind of completed with their initial health needs to more local clinics. And so, these patients are spread out all over Philadelphia. And it really doesn't do patients much good if we give them 3 months of health care and then say, okay, find a primary care doctor. So they really help to work with a patient to find a local clinic, to find a local pharmacy, and to make sure that that patient knows how to access care in their own community. So that's been great. And we're also now working on a smoking cessation counseling program tailored towards our patients. So my current role at Penn is I'm an assistant professor in clinical medicine. Like I said, I'm the medical faculty director of the refugee clinic. I also work half-time at District Health Center number 4, which is in West Philadelphia. I have a big panel of patients in that community that I take care of. And My role is also in the primary care residency program, where I help to train our residents and give them experiences in community medicine, and hopefully improve the primary care pipeline. So just a little bit on my background as to how I got here. My undergraduate degree was in community medicine. I started with a very public health perspective. I wasn't planning on going into medicine. And I ended up doing a master's in public health, and many of the skills that you can get with a broad degree, such as a MPH, really helped to enrich my background and has really helped with my clinical skills in a way that it's hard to describe, but it just has made me a much, I think, better clinician. And so the biggest skill that I learned from my master's in public health was just kind of thinking about the social determinants of health and how that frames an individual's own health. And so, you know, you're thinking about the health of a community, and then you have your patient within that community, and what specifically, you know, impacts that patient. And then when I completed my medical training here, I did participate in the Botswana UPenn partnership rotation, where I spent time at Princess Marina working in that hospital. And I also worked in the Bridging the Gaps program here, which for those of you who don't know is a program that connects health professional students across the city, working in teams, sends, you know, out to a community site. I worked at Early Head Start, talking to new moms about immunizing their kids. So that was a great experience. And then when I was a resident, I worked in a variety of different clinics. And that was probably the best experiences I had in residency. I worked at the LAC Center, which is in a clinic that provides comprehensive primary care for patients living with HIV in Philadelphia. I worked at Prevention Point, which is a medical clinic that operates inside a needle exchange program in Philadelphia, and then the refugee clinic. After I finished, I really wanted to hone my clinical skills, and I spent 5 years at Geisinger Medical Center, which is kind of in the middle of the state, doing some rural medicine, just gaining a lot of skills, and that was a good experience. So the major skill sets that are probably most important to me is patient care skills. I am a clinician at heart. I would say early career as well, and you know, first and foremost, I am a physician providing care to the patients that I see, and so that always comes first. But then understanding the social determinants of health has been very helpful, because I feel like I'm able to see the patient in front of me through the lens of population health and the circumstances that they're coming from, and it helps me to understand better, some of the decisions that they make and some of the health outcomes that come from that. Obviously, I've worked in a number of different clinics, and those diverse patient populations have really helped to frame the way I'm able to practice. And I can't emphasize enough how important all of those experiences have been to me. When you work in a new clinic, you are always learning the new ways that the clinic operates, and you're taking pearls about what works and what doesn't work, and that has helped me as I've moved on to different clinics just to help improve operations. And then, as many people have said so far, team building is of utmost importance. If you can't work with a team, you can't get anything done. Some of the best clinical experiences happen when you have lots of people working from different backgrounds on the same problem. And that's it. Yes.
Okay, so why don't we just open it right up to the group? Because I know people are probably getting hungry, and we'll just get started. So, yes.
Yes, I have a question for Dr. Rudy. So my question is, so how would you say you managed to juggle between assisting these underdeveloped nations or so, while also not infringing on sovereignty? How do you, where is the line drawn where you realize oh, this is to the extent?
That's such a good question. When I first started working internationally, it was early. It was the 70s. And so there was a really big focus on cultural relativity and really respecting culture. And so if you saw practices that you thought were personally offensive, you just did not, it was really important to understand relativity of culture. But over time, I think the core for me has been around human rights and sort of what are the violations of this. There's like this universal core truth around respecting the integrity of the individual. And so, and I've been more, and I think as I've gotten older, I've gotten braver about speaking truth to power. And there's less at stake for me. So I'm like, for the Minister of Health in Rwanda, that's not right. Don't do that. So I'm probably not a really great example of the moment of being super diplomatic. But I think the biggest strategy for me is just really the compassion, using your sense of compassion to understanding how complex these issues are, and that you are a visitor. This is their culture, this is their country, and they're the stakeholders, and you are in partnership with them. I just wrote a blog on this, the 5 business lessons I've learned from my colleagues in public health overseas. I'll send that to you guys, because it's really like all these terrible lessons I've had to learn over the time.
I'm not sure who can best answer this question, but I'm a professional already over at CHOP, and I've been there about 10 years. So what's the best way if you're kind of not in undergrad anymore, but you have some experience, you've traveled, you've done some volunteer work, things like that. Just how do you kind of segue into, if you're trying to transition into global health? I don't know who can best talk to that.
And what's your professional background?
I'm a pediatric nurse practitioner. And then I've been at CHOP since for 10 years, so 2007. Yeah.
The strategies that I've seen are people have, if they want to get into global health and they have a heart for a particular country, they'll move to that country. And then they'll seek employment within that community. Networking is really important. But the employers and the employer studies say that they'll hire people with domestic only and mid-career domestic only if there's some way that you can frame what you do that makes you a particular interest to them. So it's some sort of technical debt, some sort of population, some sort of, what is something that defines you in particular that makes you stand out from other global health professionals.
And I would also add, I think Sharon, you touched on it, there are opportunities to participate in global health in Philadelphia with, refugee communities or displaced communities. Networking has been very instrumental in my career development. And it's not about knowing 100 people, it's about knowing 4 people really well. So I would identify those 4 people that are connections from what you're doing now. Working in health, I'm guessing you probably know people that are, working either with these populations or in these countries, and, talking to them, I think generally it's a pretty collaborative, and people are happy to discuss and chat about careers, I'd say.
Ryan, could I just jump in here for 1 second? One of the things that Sharon said, which I think, has to do with the domestic experience versus international experience. We all have to have our international experience, the first one, at some point, and, we're not born with an international experience as a rule, many of us. So we are always looking for good people. And I would just make the comment that nurses are the most important part of healthcare, and that probably includes cancer care as well. So I think to Ryan's point, find a couple of people who are doing this, and the best people we have on the ground had their first experience somewhere. And we're happy to try to figure that out with you.
And if you're interested in refugee populations, CHOP has an awesome refugee clinic, and if you just shoot me an email, I'm happy to hook you up with them.
You got a lot of walk
Okay, over here.
This is kind of a two-part question, so sorry. The first one's to Dr. Chuchel. You said that you didn't initially plan on going to medical school. I was wondering what kind of changed your mind after your different experiences. And then directed at Sean, working in the global health sphere, have you ever found it difficult doing your work without a clinical background? Because that's kind of something I'm weighing right now.
So I can tell you what changed my mind. I'm not sure that had I gone back, I would have stuck with this decision. But it kind of goes back to actually what Dr. Rudy was saying is kind of not only knowing what you love, but also knowing what you're good at. And I was doing a lot of public health and research on cancer screening and what barriers women had to receiving cancer screening. And I must admit I got a little frustrated with the population perspective, and I didn't see results fast enough. And I really wanted to have that that one-on-one. I see what I am doing, and I'm seeing the effect of it. And that's why patient care kind of appealed to me. And I'm good at the patient interactions. I'm good at interacting with people and helping them to kind of coordinate the system. And so it was just a better fit for me. And I think ultimately it allowed me to use my population kind of skills that I gained through my public health experiences, and still be able to get that one-on-one interaction that I craved.
And in terms of not having a clinical background, I think it might actually be liberating. A lot of people that I went to school with who had a medical background or in medical school at the time, typically between years 3 and 4, they have a clinical perspective that I think can be hard to shake. And when you're dealing with population health, it's a different perspective. And in a lot of low and middle income countries, I was in Kenya in November, and the vast majority of people in the Ministry of Health or they're working in a public health department, they come from the MD, MPH school rather than maybe a PhD or MPH only track. So I think that offers me a diversity of experience, and I think that's changing. I think in the future in a lot of low and middle income countries, you'll see more people working in public health departments that are maybe don't have a clinical background, but I get by just fine. I think it's a good perspective to have, and there are a lot of people who have clinical and population level skills and do a great job, an amazing job. I mean, some of the top people in the field, but I do think there's having just that population level perspective is also, it's valuable.
I could not agree with that more. I think I'm just speaking from the medical perspective, but medical training is tedious, and a lot of it has nothing to do with global health. And you have to really be interested in it to want to go through 7+ years of medical training in order to get the skills to then be a clinician or designing programs in a global health context. And you have to really want to do that. I would never tell somebody, if you want a global health career, you should go to medical school. You should, there's lots of different opportunities, and depending on what you enjoy most about global health, you can kind of find your niche in that area.
I wanted to just add that there is a kind of, because so much of historically international development was the transmission of the medical model, there is this sort of vestige of, it's like you get points for being a physician. You just do. You just do. Like I was at WHO for 6 months, and they have a rule there that you can't put a doctor on the sign on your door unless you're a physician. Well, I'm a PhD, so I put the sign up on my door. It's like, what? You can't. But so there is a little bit of that. I think the important thing is getting some sort of direct service. You need to have I love Peace Corps because you have your end user experience. If you don't have that ability to if you haven't been friends with somebody who has suffered, or been a health provider or suffered in those conditions, you're missing. And when I see high-level political people who get into health at that level and they haven't had that experience, I think that Dr. Schulman mentioned it, you can see it and it matters. So you want to be grounded in having had some field understanding of what all you're doing, like what's that, what is it, how does it impact that end user? The other thing I was going to say is that we don't hire just health people. In the Global Health Fellowship Program, we have engineers, we have MBAs, we have veterinarians. You can't almost imagine a technical area that doesn't have a connection. Child psychologists, just there's kind of like everything. So if you're just get clear about what you love and what you're good at, and if you want the world, you want to work in this world, you will find a path. You will find a path.
We'll have one more question. Yeah.
But I'm an undergrad student studying anthropology, and so my question is for all three of you. And basically, what is the intersection between responsible global service and responsible global health, and then real practical global health work? Traditionally, it's been thought of as a kind of an imperialistic and somewhat exploitative field in terms of there's a clear subset of people from North America and Europe going to Africa and Latin America and Southeast Asia and doing work, and then they get to come home and we get to sit in this beautiful room. But how do we think about moving forward, really putting an emphasis on partnership?
I'll tap in here. I think a thread that you saw throughout the presentations today was capacity building, and my guess is that has not always been the case, or there's more of an emphasis on it now than ever. And finding local partners when possible. So, for instance, the work we do, if there's a research project that we're going to do in Senegal, we really want a Senegalese firm to be bidding on that and to be conducting the research. I don't know if someone else
I was just going to say that I think you have to find your own personal level of comfort with it. I personally could never feel comfortable with that, with kind of, spending time abroad and then coming back. And I find that there's enough underserved communities right in front of my face that I can, spend my time here. But I think everyone finds their own kind of balance that they feel good about.
I think it's a really interesting time of transformation for us, and some great opportunities exist. And I really think that academia can lead the way on this, because one of the low-hanging fruits in academia is partnership with foreign universities. And there you see a lot of that happening. The problem is that there is inequity in two areas that the foreign universities are now complaining about. One is how the money gets shared, how resources get shared. And it's not just the academia's fault, it's the donors' fault too, because they are biased towards giving money to American universities, and they need to be doing it equally. The other is, and this, I blame academia for this, it's the credit that is given in academic publications around, they do research together, but who are all the first authors? It's always the American university people. That has to change. But it's such a, the most forward-thinking global health professionals that I know are looking at reverse programming. They're looking at, we go to you, we share what you know, you come to us and you help us with our problems. And it's a real sort of equalization. And one of the really sort of kind of odd outcomes of the Trump administration has been, and is starting to be, this sense of the United States as this hurting country
who needs help. We're really we're sort of falling off of our pedestal, and that's actually a good thing. So with all of our resources, we really are a member of the global community and really need support from others as well.
Okay, with that, I want to, so that was a great question, actually. They were all good, but that one was really good. I want to thank all of the panelists today, and in particular, thank all of the individuals who helped bring today together. Grace Ann from the Center for Public Health Initiatives and from the Center for Global Health, Andy Kat, Tazeen, and of course, our director, Megan. It's been a pleasure. There's lots of food out there. Thanks for coming. I hope it was helpful. Enjoy the rest of your day.